All right, next, Dr. Shea.
Yeah.
After seeing many medical providers to get a diagnosis, I, like many other patients, was told my symptoms could be psychosomatic and to go see a psychiatrist. I was very frustrated, but I did decide to go, and luckily I did because it was the psychiatrist who, upon listening to my symptoms of body aches, fatigue, and insomnia, who diagnosed Lyme disease and confirmed it via Western blot. What are some of the key psychological presentations that you look for with tick-borne diseases? And further, what signs and symptoms should a parent look for in a pediatric patient?
Well, I think that it needs to be broken down into kind of three different areas. One is cognition, or how one thinks. Another one is emotion, or how one feels. And the third is behavior, how one acts. Typically in an adult population, after or even prior to a diagnosis, a person is feeling out of sorts and generally goes to have their organic capacities evaluated, and that can result in an individual being diagnosed either with the illness or not having a diagnosis and being told to go to a psychiatrist. The question of going to a psychiatrist on that basis is whether the psychiatrist is in fact a Lyme literate psychiatrist and has an understanding of the organicity of Borrelia burgdorferi or the other tick-borne illnesses. And if not, then you can get into some difficulty. But if they do, and you obviously were lucky enough to meet a psychiatrist who is knowledgeable of that, they typically will recommend, depending upon what they see, whether it's a cognitive process or an emotional process, a course of medication and then also a neuropsychological evaluation to better define what the cognitive or how the cognitive domains have been affected. In cases of pediatric cases, one of the things that one has to look for is information that is provided by the parent about the change in a child's study habits, the change in a child's behavior. And if the parent does not see that, and many times there can be diverse reasons for why a family unit does not recognize that. There may be some difficulty within the family unit. There may not be a good communication sense. But the school may represent complaints that show that the child in their report card or in their behavior has declined from where they were. And at that point, what very often happens is the school recommends that a parent have a child be seen for an evaluation, usually a cognitive evaluation. That can be done by a school psychologist, but most often what happens if the school psychologist is not aware of a tick-borne illness or the presentations of a tick-borne illness, the typical thing that happens is the child is declared as having attention deficit disorder, and if it's a behavioral thing, the diagnosis du jour is bipolar disorder or emotionally disruptive disorder or emotional discontrol. Most often, pediatric cases that have a diagnosis of Lyme disease and multiple co-infections do not have a diagnosis of attention deficit disorder. It happens to be that because of the illness, there are attentional traits which decline, but that does not diagnose them as an attention deficit disorder. But more often than not, when school psychologists see this, the typical diagnosis is attention deficit disorder, which is an incorrect diagnosis for the children, and it leads to incorrect treatment.
Mm-hmm. You mentioned the family unit. The support of my family was a huge factor in my improvement thus far, and I'm aware that some patients do not have the same family or social support and feel isolated or abandoned. Why does Lyme disease and other tick-borne illnesses affect human relationships, and is there a role for family therapy?
Well, my axiomatic thought on this is Lyme disease and other tick-borne diseases are a family illness. They're not an individual illness. An individual may bring the illness and be first diagnosed. But the likelihood is that there are other members of the family that will have it also, because they typically live within the same environment, they vacation in the same environment, and while they have not been diagnosed, there is a likelihood that they may have it. That being said, if only one person in the family has a diagnosis, that immediately causes changes in all of the roles of the family members. That individual becomes the focus of attention, and that can cause problems between spouses who may feel that one may feel that the child is being pandered to. Children and siblings may feel that that child is getting too much attention and they're not being paid attention to, and therefore they go and seek other kinds of support systems, which can be detrimental. Anytime that I have an individual who is diagnosed with Lyme disease and lives within a family structure, I always ask for a family meeting and generally suggest that they have family therapy. Part of that is psychoeducational, so that everybody in the family is on the same page and they understand not only what presently is happening, but what will happen in the future. And it's to provide them both insight as well as hope. And I teach that here at NYU Medical Center to all the interns, because I'm the co-director of family therapy here. And it's very important for them to understand that when an individual has an illness, it becomes an illness that changes the roles of the family or the peer group in which they function. And if one does not have a family member, a singular person, they typically have friends, or if they don't have a collection of friends or can't feel they can reach out to them, there are support groups available that they can go to.
Thank you. And thank you to all the doctors for your answers. Next, I'm going to introduce our next patient moderator, Jennifer Crystal. Jennifer, can you please tell us a little bit about your experience with Lyme disease?
Sure. Thank you so much for having me, and welcome to the doctors. I've been a patient of tick-borne illness for 20 years, though the illnesses were undiagnosed for the first 8 years of that process. I've battled many of the worst physical and neurological symptoms of Lyme, Babesia, and Ehrlichia. After a severe relapse about a decade ago, I've moved from bedridden to remission, and though I still have some limitations, I'm grateful to now be living a relatively normal life that includes writing, teaching, exercising, and socializing. I write a weekly column for the Global Lyme Alliance, and I'm completing a memoir about my medical trajectory. I love being able to connect with other patients through my writing, and also enjoy serving as a communication liaison between doctors and patients. I'm really excited to join you all today and to ask some questions, as Jackie did, about what I learned from your panels at the ILADS conference. So I'll just, to jump off of Jackie's questions, I'm going to start with a question for Dr. Ligner. The first is that different doctors at ILADS focused on research and treatment of co-infections, one of which has been mentioned before, which is Bartonella. And just for listeners just listening in, co-infections are other infections that other than Lyme disease that you can get from a tick bite. Can you talk about what you learned at the conference about various co-infections and how those findings might inform your treatment of other infections?
Thank you, Jennifer. Well, there was quite a big focus at the Boston conference on relapsing fever. There were 3 different speakers who gave excellent presentations. And by the way, I just want to comment that altogether there were some 50 different presentations. A lot of them were given during parallel tracks, so just by attending, you couldn't go to all of them at the same time. Unfortunately, we got PowerPoints and able to review them. But there was quite a richness of the offerings there, and a lot of them were of very high quality. In terms of the co-infections that I commonly encounter that are most problematic, for me, it's Lyme, Bartonella, and Babesia. Those are the kind of the 3 big ones, because each of them has I use this term, a penchant for persistence. But in terms of what was focused on at the conference, like I said, there was quite a focus on relapsing fever. Sally Cutler, who's from Great Britain, gave a great talk on relapsing fever in Africa and worldwide. Dr. Ogo from Nigeria talked about relapsing fever in Africa. And Diego Cadavid gave a great talk on the pathology of relapsing fever. So we've learned fairly recently that in addition to the Lyme organism, there's another Borrelia that is fairly common in the same ticks that can transmit Lyme, that is to say the deer tick, but it turns out it's not Lyme, and that the name that's been given to that is Borrelia miyamotoi, which was first described in Japan in 1994. And actually, there's an entomologist currently at Yale, Derlin Fish, who many years ago perceived correctly that there was another Borrelia in the deer tick, and he tried to get people's attention. He's quite well connected in the biomedical research establishment, and he basically got ignored until about 10 or 15 years ago. In the former Soviet Union, there were human cases of that described, and all of a sudden there was a lot more interest. And in the last number of years, there's been more support and research on Borrelia miyamotoi. There was a case that was described in western New Jersey in Hunterdon County of an elderly woman who had a meningitis, and they looked at her spinal fluid, and they were able to see numbers of Borrelia in the spinal fluid, and that's unusual for Lyme because Lyme is usually not present in large numbers. The relapsing fever organism, like Borrelia miyamotoi, are often in the blood, for example, in large numbers, where they can be fairly readily seen under light microscopy. Anyway, that case was reported in the New England Journal of Medicine not too many years ago. So there's been a lot more focus on that. The treatment for relapsing fever Borrelia, that is to say Borrelia miyamotoi, is similar to Lyme, although there's less known about the natural history of Borrelia miyamotoi relapsing fever than there is of Lyme disease. And the other thing about relapsing fever, there in other parts of the world and even in the American West, a different kind of tick typically will carry the relapsing fever organisms, what are called soft ticks. In the West, Ornithodorus, and in Africa, there's many other, they call them argacid ticks. Those ticks, unlike the deer tick, which attaches and stays on for days at a time, these other ticks, they feed and very briefly, so they often will bite people during their sleeping time, and they won't even realize that they have had a tick attachment. So another thing about relapsing fever in Africa, the borrelioses in Africa are not what we call reportable diseases. Like in this country, Lyme is a reportable disease, but in Africa it's not reportable. And there's much more focus in Africa on other infections, vector-borne infections like malaria. So what Dr. Ogo pointed out was that oftentimes people will have high fever and it will be assumed that they have malaria and they'll be treated as for malaria, but the infection won't respond because it's actually a borreliosis. And that's a big problem. Again, there wasn't. I didn't see too much at the conference about babesiosis, but that's also a very big problem, and the treatment of that is quite different than the treatment of Lyme disease. Did I answer your question, Jennifer, or did I focus on more?
No, that's great. It's just so important for patients to hear about these other diseases other than Lyme, to know about them, and also to know about how these are issues worldwide. So that's very helpful.
Yes, these
another
are
question. Sorry,
sure.
Go ahead. No, go ahead, please.
No, I agree with you. This is both Lyme disease and the relapsing fever borrelioses are global phenomena. It's not just in the United States or a single continent. And
not just in New England, as many people think.
Not at all. I think
right.
I think almost every state in the United States has had cases reported. I'm not sure. Maybe Hawaii might be one state where it hasn't been reported. I'm not sure about that. I thought it was like almost every state has been reported.
It's so important for everyone to hear that. Another question I wanted to ask you is that during a panel Q&A at the conference, you mentioned that Lyme is variable, and I know this is true for other tick-borne diseases as well, that some people are devastated by it and some people are able to keep it in check. This has certainly been true in my own experience. I personally was devastated by it, but I know other patients have had an easier time fighting it off, and others have been even more severely debilitated than I was. Can you speak to why Lyme is so variable?
Well, for one thing, it's been recognized that there are many different strains of Borrelia burgdorferi, and some of the strains may be, as we say, more virulent, or some of them may focus on different organ systems, such as the nervous system or the heart. So part of it is, what strain, happens to infect you, and then to make things more complicated, people who live in tick endemic areas or tick infested areas, I should say, they often get bitten by more than one tick, and it's very possible that more than one strain can infect them and affect them. Then on top of the different strain variations, each human person obviously has a different immunogenetics, and it's been very well demonstrated in a mouse model. In fact, Dr. Kadavid, talking about relapsing fever, was pointing out that some strains of mice can be infected and have a very, very mild illness, and other strains of mice have a devastating illness. And Janice Weiss, who's a PhD at the University of Utah, has also shown very similar things for Lyme disease. Depending on the strain of mouse, I should say, some can have a very mild illness, and some can have a devastating arthritis that completely incapacitates the animal. So, strains of mice can be inbred, and you can sort things out, and look at the different strains. In human beings, each of us has a very complex immunogenetics, and that's why it makes it very difficult to make blanket statements about what Lyme is or how it presents, and also how it needs to be treated in any given person. So many of us have found that you really do have to individualize the treatment, find out how intensive the treatment needs to be for a given person. Some people respond very well to rather simple treatment, and others require combinations of agents, and some require parenteral, which means either intravenous or intramuscular therapy. So it's not like one size fits all. You can't just say, well, everybody should be treated with this or everybody should be treated with that. And then every person, not only their immunogenetics affect how they respond to the infection, but also their immunogenetics determines how they handle the different treatment options, how their liver, metabolizes different antimicrobial agents or other supplements. So you really have to be thoughtful and devise a plan, but also whatever plan you devise, you have to be willing to realize that you might have to devise the plan depending on whether the patient tolerates the treatment, whether it's having a good effect or a bad effect, and it requires a lot of improvisation, hopefully informed improvisation and thoughtful, but you just can't make a blanket statement about how everybody should be treated, because everyone's different.
That's so important for listeners to hear. Thank you so much, Dr. Lichtner.
Surely. Thank you.
My next question is for Dr. Shea. Dr. Shea, at the conference, a few doctors spoke to the fact that neurological and psychological manifestations of Lyme are secondary to the disease, meaning that they are effects of Lyme, but not the root cause of a patient's problems. This is an important reminder for me as a patient who has had to define that difference for others and recognize it for myself. Can you speak to that a little bit about the fact that those manifestations of Lyme are secondary to the disease and not the root cause?
Well, I certainly can speak to the psychological components. It depends upon whether, of course, the individual brings a psychological a component to the disease, or the disease brings it to the individual. That's a whole different question. But more often than not, what happens is the disease occurs, and then as a result of that, certain psychological components sally forth, and that could be a result of the organic effects of the disease, or it could be a characterological makeup of the individual in being able to deal with the disease. So what most often happens is that the disease, as it continues, takes a toll on the individual's stamina, and that takes a toll on their mental health. There are also neurological components of it that interfere with the cognitive aspects, how a person functions, so that their attention may be off, their memory may be off, their executive functions, their ability to multitask. And when an individual recognizes those things, and that is more secondary than primary, because often they don't recognize them immediately. But when they do recognize them and become aware, then they become more concerned about the problem, and that concern translates itself into anxiety and depression. And therefore, it's important at that point to make sure that an individual gets an intervention which is psychological in nature, meaning either individual psychotherapy or individual, if it's cognitive, individual cognitive mediation. But really the way to know that is to have a full neuropsychological evaluation done, because that will evaluate the level of cognitive impairment. It will also evaluate the level of emotional impairment. And it will ask questions around how one deals with that, which is the behavioral signs. And having had that done, then you can target a treatment protocol, whether it be individual psychotherapy, if those are the primary responses to the disease, or if it's cognition, then that would be the way one would direct their therapy. It's never one or the other. It usually is a combination of both cognitive problems, and those cognitive problems exacerbate the psychological aspects of a person's functioning. There may be times when a person has a primary psychological problem that then opens up questions about cognition. But in this disease, it's much more often that a person has the cognitive component, and then that bothers them and either affects their work or their school process, and that then causes a decline in their ability to function psychologically.
That's great. Thank you so much, Dr. Shea. My next question is for Dr. Shore. Dr. Shore, one of the reasons my own case of Lyme went undiagnosed for so long is because testing is so faulty. Dr. Ligner spoke to this a little bit before. Can you explain to listeners why current tests are so unreliable, and also talk about the latest research on diagnostics that we learned about at the conference?
Right. As it turns out, there was overlap between your questioning and your colleagues' questioning. So I've answered much of this, but to reiterate the high points and a couple of other comments. One is the emphasis is that the two-tiered system that I mentioned earlier is not very sensitive. If we're lucky, it's 50% sensitive. So every other individual with real Lyme disease undergoing this paradigm of testing is going to be told by their clinician that the test is negative. And unfortunately, many clinicians take that as de facto ruling out Lyme disease. In fact, there's a law that was passed in Virginia 3 years ago that requires clinicians, when testing, to communicate that if the test is negative, it doesn't rule out the disease. They need to be followed clinically. In addition, it's testing the immune response, the antibody response, and paradoxically, the sicker an individual is with Lyme disease, which can adversely impact immune function, the more likely their blood test is going to be negative using this paradigm, as opposed to some of the other technologies about which I mentioned earlier. So the sensitivities of the paradigm are poor to begin with, and they're even that much more insensitive or less sensitive in the sicker individuals. And I talked about newer technology a moment ago.
Mm-hmm. So on the flip side of that, of diagnostics, what new research is being done on prevention?
Well, the major discussion was vaccines, and there are human vaccines, and that I'll talk about briefly, looking at different proteins on the organism Borrelia burgdorferi. And I'm not sure this was discussed at the conference, but there's some discussion about vaccines for the saliva of the tick, because that is going to be a more broad spectrum coverage. Because one of the concerns that we have in relation to Lyme disease is not only the multiple strains to which Dr. Liegner alluded, but the fact that there are so many co-infections, and if you have a vaccine for one organism, you're not necessarily going to protect against others. But if you have a vaccine against the saliva that amounts an acute immune response at the time of the blood meal that's taken by the tick, there's a potential that you can have a more broad spectrum response. Then there's the concept of immunizing the mice. There's a study being done in Massachusetts that because understanding the life cycle of Borrelia, where the tick, when it hatches, is sterile. It's not infected. It has to take a blood meal of usually small rodents and very commonly the white-footed mouse. And there's research being done to somehow sterilize the mice so that when the tick takes a blood meal, it's not necessarily going to become infected. So there is some exciting work being done.
That's very exciting to hear. Thank you so much, Dr. Shore, for filling us in on that.